So we'll continue with digestive disorders, looking at disorders of liver and pancreas. Really an extension of the liver is gallbladder, so we'll go with that first, because gallbladder disorders are quite common. Very common for gallbladders is cholelithiasis. Chole means bile, lith means stones, ias is the condition. So the condition of having stones made of bile, gallstones. Gall is the Old English word for bile. So gallbladder, cholecyst. So this is solid crystallizations in the bile. The bile salts crystallize, and we get these calculi. They can cause a lot of pain. They can lodge in the ducts and cause backup. And they can cause cholecystitis, which is inflammation of the gallbladder and or the cystic duct. Cholangiitis is inflammation of the bile duct. Usually it's got some infection. The chole, and I always have trouble getting my mouth around this, choledocolitis is the same as cholelithiasis, except the stones have moved down the biliary tract and are obstructing bile there. Now, I'll say a couple of things that I know of gallstones that are somewhat counterintuitive, and you will be dealing with this a lot in practice if you deal with these patients, because people don't understand. So the gallbladder squeezes in response to fats being in the chyme, and so and you get cholecystokinin is the hormone that responds to fat being in the food, which then causes gallbladder to squeeze. The gallbladder's job is to take the bile that's produced by the liver and concentrate it. So the bile goes in, and then water is absorbed out of it, and we have a more concentrated form of this emulsive salts that is bile. And you eat a fatty meal and you squirt that out and you mix it, and it emulsifies the fats and helps you digest fat, and on and on and on. So the problem is that if the bile sits for too long, it gets more and more and more concentrated, and if there's some sort of a nidus, a focus for crystallization, could be an infection, could be a number of things, but the crystal will grow and you will end up with this gallstone. It's almost like what can cause it is not enough fat in the diet, because then you don't turn over the bile quick enough and you get the gallstones. But what's counterintuitive about this is then when you have the gallstones, fat in the diet causes the gallbladder to squeeze, and it moves the gallstone maybe into the duct, into the cystic duct, and causes pain. So leading up to prevent gallstones, you really need a certain amount of fat in the diet. But after you have gallstones, fat in the diet can cause pain. If your idea of avoid pain, then it's probably a good idea to avoid fat But if you completely avoid fat, then the gallstones will probably grow. So you kind of have to take it all kind of a bit with a grain of salt. So if we look at where this can all be, not very often does the stone form up in the liver. It usually forms here in the gallbladder and in the cystic duct, which is this duct that goes to and from the gallbladder. The hepatic duct comes from the liver. When the hepatic duct merges with the cystic duct, it becomes the common bile duct here. And then the common bile duct merges with the pancreatic duct to become the hepatic duct, right? So there is an ampulla here, right? The hepatopancreatic ampulla, and then the papilla is here with a sphincter called the sphincter vodi here. And so it merges. So sometimes the stone will lodge here and cause inflammation of the gallbladder. If it lodges here, gallbladder and cystic duct. If it lodges here, it can back up the bile here. So if the obstruction's here, the bile can still enter down here. If it gets down too far, if it gets down in here and blocks, then it's going to block the pancreas. And the biggest problem with the pancreas is that digestive enzymes then can't mix with the food, and the pancreas can auto-digest. We'll get to that shortly. So they can form anywhere in the ducts or in the gallbladder. It's usually a cholesterol stone mixed with bile pigments, maybe with calcium salts. We're probably producing small stones all the time, and they cause no symptoms because they just pass and secreted in the bile. But if we obstruct, if they're larger stones, they'll obstruct the flow and cause pain, which goes to the right subscapular area, so the right shoulder behind the scapula. So for some reason, women develop them more often than men. High cholesterol levels will cause it because they're made of cholesterol. Obesity can be a bit of a problem. Multiparity, so if you've had lots of kids, for some reason that seems to not help. And so it's probably women because of estrogen, so estrogen supplementation probably is a problem. Problems with the liver, alcoholic cirrhosis, biliary tract infections can cause it. Hemolytic anemia is a bit of a problem because what's happening here is the bile is the way we get rid of the pigment from the hemoglobin. And so if we have hemolytic anemia, we have way too much of this waste product to be gotten rid of. And it can change the consistency of the bile and can form gallstone. If you get an obstruction, you get sudden, severe waves of pain, and it's radiating pain. And then nausea almost invariably happens. Vomiting is common. The pain continues, and eventually jaundice will develop because the bile will back up, and the bile not only creates the bile salts to emulsify fats, it is the way we excrete the bilirubin, the remainders of red blood cells that we can't recycle. So the pigment, which is that yellow pigment, and so there's no place for it to go, and so it ends up in the blood. We urinate some of it away, and that's why urine tends to be yellow, but it'll back up and it'll settle in the interstitial fluid and turn you yellow, jaundice. And it is very sudden pain. About 5 Christmases ago, we were all sitting around my wife's uncle's place and eating snackies, opening presents and that kind of thing. And all of a sudden my son went, "Oh, I don't feel well." And he had this pain, substernal, like in that hypochondriac region, and pain right to behind his right scapula. So up we go, he and I go to emerge, and sure enough, it was a gallstone. He had to have his gallbladder removed. But he was having just a normal Christmas day, talking, and just everything was normal, to doubled over in pain in the course of 10 minutes. If the obstruction is complete, you can end up with a ruptured gallbladder because the inflammation gets terrible. Now, a lot of times people end up passing the gallstone. So what will happen is it'll be obstructed, and the pressure will push it, and it'll move and push and move and push and move until it ends up being put into the duodenum. As soon as it's put into the duodenum, the pain stops. You end up pooping out the stone eventually, but yeah, the pain stops immediately. So sometimes they just remove the stone laparoscopically. Sometimes they have to remove the whole gallbladder, cholecystectomy, and that's usually laparoscopic as well. After you've had the surgery and you had your gallbladder removed, you have to watch your fat intake, because you don't you don't emulsify fats and therefore don't digest them very well, and you can end up with setoria, with fatty stools that are pretty foul smelling and float. Another thing that I think you have to be careful of, although it's not in very many textbooks, but I had professors talk about this when I was in school, and I kind of subscribe to the idea. It doesn't hurt anyways. There's problems with absorption of the fat-soluble vitamins. So taking vitamin supplements is probably not a bad idea. So you can maximize the absorption by maximizing the intake of them. So jaundice is not a pretty sight. It looks like this. I've seen people look this badly jaundiced. I had a neighbor who ended up with liver cancer, and she had jaundice, and she had been away, and when she came back, I went to see her, and she looked just like this, and then the next day she was in the hospital. A month later, she was dead. The whites of the eyes, you notice, it really show it. But this is an interesting picture because the teeth look so white, and it shows you that it's not just a yellowed photograph. Jaundice can happen because of a few things. It's not just gallbladder disorders. So we talk about 3 different causes of jaundice. There's prehepatic jaundice, which means the problem is before the liver. And the pigment that causes the jaundice is from the destruction of red blood cells, the normal turning over of red blood cells. If you have excessive destructive of red blood cells, like hemolytic anemias, or a transfusion reaction, meaning you've gotten the wrong blood type, either one of those things will really increase the amount of bilirubin that's there, and the liver can't handle it, can't excrete it in bile, so it ends up building up, and you can have this prehepatic jaundice. As far as I know, as far as I understand, the jaundice of newborns is this. When a baby is in the womb, it's getting its oxygen from the placenta, and so it has enough red blood cells to carry the oxygen from the placenta to everywhere in its body. When the baby is born and starts breathing, the availability of oxygen is higher often, and so now the baby has too many red blood cells that aren't necessary, so they're gotten rid of, and the baby can get a little bit of jaundice. Their livers aren't also functioning very well because they're really not eating, and they're not until birth. So shortly after birth, they've just started eating, and so it's not a measure of disease. It's just almost like a homeostatic rebalancing of the newborn. So prehepatic jaundice has to do with excessive destruction of red blood cells. Intrahepatic is there's a disease within the hepatocyte, right in the liver, and so the liver is not coping with being able to excrete this excess pigment into the bile, because the bile is not being produced. So hepatitis it's common. Cirrhosis, jaundice is common. Post-hepatic jaundice is what we just have been talking about. Issues with the pipes that leave the liver. So obstruction of bile flow to the duodenum to be gotten rid of. So it backs up. So either it's in the gallbladder or in the bile ducts someplace. Right? Tumors can also cause this because tumors take up space and they can push on the tubes. So we can go down through this. Okay, so in the liver, one of the things that happens is the bilirubin, which is the heme with the iron taken out of it, is in an unconjugated form. And then it's enzymatically changed into the conjugated form, which is what is excreted in the bile. So if there's a problem with conjugating the unconjugated, then we can end up with that, right? So intrahepatic prevents conjugation and the excretion. Make sense? And so it backs up into the blood. So we can measure it in the blood. So we can look at the conjugated bilirubin. So we take the total bilirubin and subtract the conjugated stuff, the direct stuff. We have the unconjugated, the indirect. And from that, we can determine whether it is prehepatic, intrahepatic, or posthepatic. So we look at the serum bilirubin levels, but we also look at the stools, because it is really the reason that your stools are brown is because of this pigment in the bile. Doesn't matter what color the food you eat, it's that. So pre-hepatic, we have this unconjugated bilirubin level elevated because the liver can't process it because it's being made too fast. In intrahepatic, both unconjugated and conjugated go up. Right? In post-hepatic, you get an increased conjugated, but not unconjugated, because it's being made, it's being conjugated in the liver correctly, it just is not being released. And then it's not getting into the duodenum and mixing with the food, so the stools are light colored. We have blonde poop. We've already looked at this, I'm sure, in anatomy and physiology classes, but what happens here is blood comes in, goes through the sinuses, is brought into the hepatocytes. The back door of the hepatocyte is where the bile comes out and the bile duct happens. The hepatic portal vein comes from the digestive system, and it's bringing blood, and it mixes with the vein from the arteries, or the blood from the arteries, drops off nutrients and everything that needs to be processed. What gets processed gets put back in the blood, goes to the central vein, which then ends up in the vena cava and going into direct circulation. So the triads here at the corners have a bile duct, or a bile interlobar bile duct, a hepatic portal vein, and an artery, and then there's a central vein. Okay, hepatitis. Hepatitis is a real problem. It's inflammation of the liver. And anything that causes that inflammation, which could be infection, or it could be other irritants that are non-infectious, it's still hepatitis. A common cause of hepatitis is from alcohol, especially long-term alcohol abuse. And what happens is alcohol metabolizes to acetic acid in the liver, and it causes histological changes in the liver where fat gets deposited. And so you end up with a fatty liver. And then that fat inhibits the liver functions and can cause hepatitis. There's idiopathic fatty livers. Sometimes it just runs in families. I currently have a patient, she's been a patient for about 15 years. I think I've seen her every month for 15 or more years. And she's been diagnosed with fatty liver. And honest to God, she hasn't even had a glass of wine in the length of time I've known her. Now, she has some other health problems, some diabetes and things, and she's on diabetes meds. So maybe that's causing it, but they're calling it idiopathic. They don't know. But she definitely has this fatty liver. In culinary circles, they give geese fatty liver by feeding them alcohol, and that's what foie gras is, fatty liver. A bit of a delicacy. Okay, viral hepatitis is an infection that affects the hepatocytes, and that is an infection of the liver itself. Sometimes you can get hepatitis because of systemic infections, things like mononucleosis or amoebiasis. So amoebas can cause release toxins that end up going to the liver by the hepatic portal vein and cause irritation and therefore hepatitis. Chemical or drug toxicities, obviously, because again, these things tend to be ingested, and the organ that they go to from the digestive system is the hepatic portal vein and end up in the liver and irritate the liver. So hepatitis isn't necessarily all viral hepatitis, although that gets the lion's share of attention, which is going to have now. So there's 5 different causative viruses. What we worry about is inflammation and maybe necrosis in the liver. The liver gets large, tender, edematous. The viruses are A, B, C, D, and E. They are all different viruses. They're not related to each other except that they seem to target the liver. So Hep A is a little RNA virus. It's infectious hepatitis. It's transmitted by fecal-oral, inadequate sanitation or hygiene. Contaminated water or shellfish are big for this because shellfish filter the water. So be careful about eating raw oysters in Mexico, that kind of thing. Fecal-oral, like it'll come off money, it'll come off, various things. Sanitation is the big thing. They're saying that it used to be, they said that hepatitis A wasn't sexually transmitted until people started reporting that it in fact was. And further study has shown that it's got more to do with anal intercourse, that the virus probably is existent in the digestive system. It hasn't affected the liver because it hasn't gone to the liver yet, and gets transmitted that way. Now, I tend to think that it is because of inadequate cleaning between anal intercourse and anything else, probably oral, because you can almost see the fecal-oral route clearly from that. It creates an acute hepatitis, very tender and edematous liver, painful, but it tends to be self-limiting. The immune system seems to take care of it, and there's no chronic state, and there's no carriers. People that have it have it. Before the liver starts acting up, it starts shedding, the virus starts shedding out the poop. And so that's one of the reasons the fecal-oral route is nasty, because people with this virus, the virus will leave in the bile, it enters the digestive tract, becomes fecal, and then through contaminated water and that kind of thing, other people can get it. It's one of the main reasons why you want to get the Twinrix before you go to a lot of these places with less regulation about sanitation. So travelers, healthcare workers, food care workers. I mean, it can be a real problem, you can imagine, for PSWs that are changing diapers, etc. Yeah. But the good thing is that it doesn't become chronic, although it can cause a lot of liver damage. Hepatitis B is a DNA virus. It seems to be common with HIV positive people, because it's not immunocompromised. It seems to be a problem. Half of the people with it are carriers. They have no symptoms, but they're contagious. And the biggest problem with this is that it can cause histological change and become chronic inflammation. Infected blood is a big spreader of it. So this, it can be from sharing needles, it can be from blood transfusions, it can be just cleaning up blood. If somebody is hemorrhaged or something like that. It's the one that the tattoo parlors have to be very aware of, and why they're heavily regulated and have to be kept clean, because one person gets a tattoo, and then if the next person and has hepatitis, then the next and is a carrier, then the next person on the same needle can get it. So that's why they change the needles and they autoclave them and that kind of thing. Luckily, there's a vaccine available. There didn't used to be, and so there were a lot more carriers out there than there are now. Hepatitis C, again, is transmitted by blood, is probably a carrier state, and as a chronic state. It gives you an increased risk of cancer. It's treated with interferon. I'm not 100% positive, but I think that there is now a vaccine available for it, and there's some other treatments. If you watch American TV, you will see advertisements, pharmaceutical ads for things that can clear up hepatitis C. I haven't read any of the studies. I don't know any of the efficacy of it. I've just seen the TV commercials, which makes me go, but not enough to make me actually investigate. Hepatitis D and E, so we're probably not going to call it a Delta virus anymore. It needs hepatitis B to work along with. It's transmitted by blood. Hepatitis E is an oral fecal, no chronic state, no carrier state. So, what happens when you have viral hepatitis? There's a couple of stages. So the preicteric stage, you have fatigue, malaise, anorexia, nausea, general muscle aching, kind of flu-like symptoms. You just feel virusy. The icteric stage is when you start to get some jaundice, stools become light in color, urine becomes darker because there's more bilirubin in that, the liver becomes tender and enlarged, and achy, so you get that right hypochondriac pain. The post-enteric stage is recovery, and it's reductions in signs, but you're weak for a long time afterwards, weeks or months after. So, hepatitis B, you get the acute infection, or you're a carrier. You have the malaise, fever, joint pain, jaundice. If the icteric stage gets really bad, you can get severe necrosis, liver failure, and death. From the icteric stage, you can either become recovered or you can have a chronic infection. Chronic infections can lead to cirrhosis or hepatic cancer, or long-term mild infection and kind of going through it. We don't have real good antiviral drugs, so really we rely on antibodies. So if we can get the antibodies before you're exposed to the virus, then so much the better. That's the point of vaccination. Rather topical in the summer of 2021, the need for vaccination as a defense against a virus. If you get it, then you need supportive measures, rest. High protein, carbohydrate, and vitamins is important, and not necessarily fats, because you want to kind of not make the liver work. Interferon decreases viral replication, but the problem is it also diminishes organ function. It's not very effective. So various cocktails of drugs seem to be involved. You'll talk more about these in pharmacology courses than in this course. You can get nonviral hepatitis by toxins. So this can be an overuse of acetaminophen. People think Tylenol is completely harmless, but it can be hepatotoxic. Tetracycline, phenothiazine, so these are medications that are used regularly. Tetracycline is an antibiotic. Carbon tetrachloride is used to be far more common than it is now. It was dry cleaning fluid, and so people would get exposed to it from having a lot of dry cleaning, and the smell from the dry cleaning was carbon tetrachloride. People that worked in those industries would be exposed to it, and it was not only used for cleaning clothing, dry cleaning clothing, but it was used to clean a lot of metals and things in prepping for paint and stuff like that. So car industries and that kind of thing used it, and guys that worked in those industries used to breathe a lot of it. So my wife's uncle worked in a body shop and ended up dying of liver disease because of the solvents, is what they said, but it really carbon tetrachloride. I knew him. It was interesting. Before I met my wife, her mother's sister was married to this guy. My roommate all through university, he was Tim's mother's brother. So one of my best friends and my wife share an aunt and uncle and first cousins, and we didn't know that until we went to a family wedding one time. It was pretty freaky. Toluene is a common industrial chemical too. It's a solvent, and it's used a lot in paints. It used to be used a lot in nail polish and things like that, and it can be pretty toxic on the liver. And so people that worked in nail salons, people that did that kind of thing, had problems. So guys that painted cars and used carbon tet and toluene as solvents for spraying cars, and in those years they didn't wear Tyvek suits or even respirators. And something else to think about, these solvents are fat soluble, so you don't just breathe them in. You get this stuff on your skin, and it enters your bloodstream by absorbing right through your skin, because it's fat soluble. And so you have to be careful about these solvents just in the presence. So a mask respirator isn't enough. You need a full Tyvek suit and hood and tape on your cuffs and that kind of thing. I find it interesting that in my lifetime we've gone from just handling this stuff without anything. I remember doing experiments in school using toluene and cleaning glassware in chemistry class with carbon tetrachloride, not even having a respirator, let alone a suit. And, you know, guys painting cars and that, you know, smoking a cigarette and not paying any attention to it. Now, oh my God, if there's like a couple of drops of carbon tetrachloride, you're in a spacesuit. Probably the much better thing. It says it may result from a sudden exposure to a large amount or from a lower dose and long-term exposure. Probably more lower dose and long-term exposure is more common. When I was in high school, I went to high school in Sarnia, and carbon tetrachloride was made by Dow Chemical, and my school bus had to go right by that plant every day, and they made it by the truckload. And right after I finished, when I was in university, there was a bad spill of carbon tet in the parking lot. What they were doing was filling a truck with it, and the hose broke, and they pumped thousands of gallons of carbon tetrachloride, went into the storm sewer, which went right into the St. Clair River. And at a dock where ships full of oil and chemicals had been docking for decades and decades and decades, and it dry cleaned the bottom of the river, and there was this, it contained this stuff, they didn't even know what was in it. And a buddy of mine was a commercial diver and was contracted to do the cleanup, and another friend of mine's brother was the lawyer that was in charge of, that worked for Dow Chemical, and he had to do press releases and that kind of thing. And it's funny because David was, the lawyer, was a funny guy, and so he decorated his office in lava lamps because he thought that would be pretty funny. And then he got fired because of it. Indirectly carbon tetrachloride. Okay, cirrhosis of the liver. Cirrhosis of the liver is a progressive destruction of the liver. It is basically scarring and histological changes where the liver is no longer functioning and is replaced with non-functioning tissue. So there's a lot of reasons for cirrhosis. Unfortunately, when people get diagnosed with cirrhosis, everybody assumes that it's alcoholic. So alcoholic liver disease is a big cause. It's a common cause of it. But you can have biliary cirrhosis, and these are immune disorders. We'll do this, autoimmune disease and that kind of thing, where the liver gets attacked autoimmunely, and you end up with cirrhosis. Post-necrotic cirrhosis happens because of long-term exposure to solvents and these sorts of things, or some of these chronic viral hepatitis things. And then there's some unfortunate people that have genetic metabolic storage disorders. So they have trouble storing and retrieving things like iron and that kind of thing. And it causes damage to the liver that can lead to cirrhosis. And what it is fibrosis, it's scarring. And this interferes with the proper blood flow through the liver. Bile might back up. Those hexagon lobes lose their organization. But the liver has a lot of function, and there's a lot of redundancy. And so you can lose a fair amount of your liver before you start to get symptoms. And so it's not necessarily going to be found quickly because people don't go for help. It's diagnosed with biopsy and liver function tests. And I think the liver function tests really are probably how it's usually diagnosed, because we tend to do some liver function blood work whenever we have like our annual physical. So at first what we have is a fatty liver. We have this enlargement, asymptomatic fat deposits that can go away if you reduce the cause, usually alcohol. After the fatty liver, you start to get hepatitis, so inflammation, and cells start to die. And once the cells die, then necrosis, it increases the inflammation and becomes progressive, and then scar tissue starts to form, fibrous tissue forms, and that becomes irreversible, just like every other scar. And so liver function is lost, which then can increase the inflammation, which can, blah, blah, blah. By the third stage, the liver is predominated by scar tissue, by fibrotic tissue, and there's just less and less liver function. So what happens? Well, the liver stops functioning. So one of the big things that you see is decreased conjugation and removal of the bilirubin. And not as much bile produced. So that will lead to jaundice. You have problems with absorption of nutrients. Less so digestion, except in fats, but absorption becomes a big problem. And the processing of those absorbed nutrients in the liver. The liver produces all of the clotting factors, the fibrinogen, and that. So that stops happening, and people start bruising like peaches. Along with that, there's, we just keep with this. So impaired glucose and glycogen metabolism, because the liver stores glycogen, and glycogenolysis to release it, gluconeogenesis, all happens in the liver. And so the liver is intimately tied to maintaining proper blood sugars. When you take the amine off of an amino acid to oxidize it to make ATP, you end up adding a hydrogen to the NH2, you get NH3, which is ammonia. And ammonia is a neurotoxin where urea isn't. And one of the things that the liver does is it combines the ammonia molecules to form urea so that we can get rid of it. And so ammonia levels go up, neurotoxic, and then you don't produce enough urea. There's lots of enzymes in the liver that inactivates hormones and drugs. So, it contributes to the half-life of hormones, and so you can end up with some real crazy hormonal imbalances. And drugs can become really easily overused, because a normal dosage is probably too much. You probably overdosed. The liver removes toxic substances, so you can't do that. The reduction of bile impairs digestion and absorption. You can get obstructive jaundice by the backup of bile. Portal hypertension is a real problem because the blood can't flow through the liver. And so blood flows directly from the spleen to the liver, and that's how the iron and the products from the destroyed red blood cells, which happens in the spleen, get to the liver. And so so it backs up in the spleen. So that means blood doesn't flow through the spleen as quickly, which means that more blood is being attacked by the spleen, and so you get increased hemolysis, which is pretty crazy, because then the hemolysis creates all this extra bilirubin, which then causes more jaundice, etc. this is where we store iron and vitamin B, and so we can't do that if you have cirrhosis. The entire portal hypertension will back up and blood will congest in the intestinal walls, in the stomach, in the esophagus. And when the blood backs up, we can have varicose veins happening here, and they can burst and hemorrhage, so esophageal varices. And then this congestion means that with the portal hypertension, the hydrostatic pressure is greater than the osmotic pressure, and so we end up with, normally we would end up with edema all over the body, but there's the edema that comes off the intestines is called ascites, and it causes abdominal distension. Another thing that the liver does is it produces albumin, which is the main osmotic protein that maintains water balance, and so we get systemic edema everywhere in the body from it. Ascites looks like this. My son, with his kidney issues, often ends up in the hospital with people with liver issues, and I've seen ascites look easily this bad. Esophageal varices here. So it's the backup of the portal. So at first everything is pretty mild and vague. You get some fatigue, anorexia, because you don't want to eat because of the congestion in your digestive system, anemia, diarrhea, maybe some pain in the upper right quadrant, so the right hypochondriac area. As it advances, you get more ascites and peripheral edema. Blood clotting goes down, so you bruise easily. Esophageal varices, jaundice, encephalopathy from the buildup of nitrogen, the ammonia, and then you die. So you try not to make it worse by removing the causes. You drain off the ascites. You do symptomatic treatment. You restrict diet. You try and balance the serum electrolytes. Paracentesis is draining off the ascites. Emergency treatment if you have a rupture of the esophageal varices. Liver transplant is really the only treatment. The rest of it is just supportive. So it's a long list, isn't it? Okay, liver cancer. Secondary metastatic cancer is probably more common than primary tumors. But cirrhosis can lead to hepatocellular carcinoma. The inflammation that's caused by this cirrhosis and the pressure put on the functioning cells can cause a dysplasia, a metaplasia, and can develop into tumors. The biggest problem with metastasis is that any tumors anywhere in the digestive system, anything where the hepatic portal vein ends up in the liver. So we can have mets from like bowel cancer, things like that. The other thing that any tumor that happens in the peritoneum can migrate along peritoneal membranes and end up there as well. So there's a lot of redundancy in liver function, so initial signs are mild. So it doesn't get caught until it's advanced. So You try and cut it out if you can, you know, the whole lobe if it's there. Chemotherapy if it's Mets. It's a pretty large tumor in this liver, this whole end of it. Okay, acute pancreatitis is inflammation of the pancreas. And really what's happening here is that the digestive enzymes that are released by the pancreas in inactive form, all the peptases get released in inactive forms and they're activated in the duodenum. If they become activated before going into the duodenum, then the pancreas will auto-digest. It will start to just digest itself. And it can happen for a lot of reasons. It can be acute or it can be chronic. If it's acute, it's a medical emergency. These people could die. The pancreas doesn't have a fibrous capsule, so one of the problems is that it can spread into surrounding tissues. And the inflammation can spread widespread. Causes a lot of bleeding and hypovolemia. You can have circulatory shock and collapse. It can be terrible. And because there's no capsule, the chemicals can end up in the peritonitis. And then you can turn into septicemia, respiratory distress, renal failure because of the lack of blood. So the real common causes for it are gallstones that lodge in the ampulla and back up the pancreas. Alcohol abuse is a big problem, especially binging. Large meals will cause a huge stress on it too. And it comes on really quickly. You get this severe epigastric pain radiating into the back. It is debilitating, severe pain. You can get this hypovolemia really quick and signs of shock. You don't get much of a fever unless you get an infection. You get the decreased bowel sounds because it basically stops peristalsis and in your intestines. So we look at various diagnostic tests, so amylase levels, lipase levels in the blood. What do we do for these people? Well, you got to stop the pancreas from producing any of the pancreatic digestive juices. And that's triggered by putting food in your mouth. And so all oral intake has to stop, and all oral intake. They use analgesics for pain relief, and IVs for shock by bringing blood volume up and dealing with electrolyte imbalances. So one time when my son was at Sick Kids, it was interesting. He was in a ward, so there were 4 beds, but there were only the 3 kids. So he had his kidney issue. He was undergoing a rejection of his transplanted kidney. The kid in the bed across from him had acute liver failure, and I won't even go into all the things that kid had, but I thought maybe the kid had cerebral palsy or something like that. He had flexures and was had lost all body control, severe neurological damage and muscular damage, all excitable things. And what was interesting, so that kid was 16, and his parents, we got to know his parents because we sat with them a lot, and his parents were showing us pictures. He was a rep hockey player and had his driver's license 6 weeks before, and he will never be out of a motorized wheelchair, just a vegetable. It was terribly sad. But the kid in the bed to the right had acute pancreatitis, and he wasn't even allowed to swab his mouth with a damp sponge. No oral intake at all. Nutrients came through IV. Everything was coming through IV. And so he was in a rough way psychologically. The pain was under control with analgesics. And so he sat there playing video games constantly to keep his mind off the fact that he couldn't, his mouth was so dry and he was so hungry, his stomach was so empty. But, and basically what they do is they stop until the pancreas heals. So it's a long time. So you get this, whatever precipitating factor happens, which activates the enzymes inside the pancreatic ducts instead of outside. So then you got autodigestion of the tissue, which leads to necrosis and really bad inflammation. And then the enzymes and cell contents leak into the general circulation to cause shock and coagulation and respiratory distress. They leak into the peritoneal cavity, and really they digest the peritoneum and other organs. So you get severe pain, hemorrhage, shock, peritonitis, those sorts of things. Terrible. Look at the number one risk factor of this, smoking. For pancreatic cancer. Pancreatitis will do it. Well, obviously, inflammation and necrosis will lead to dysplasia and metaplasia. Usually it's an adenocarcinoma because it is glandular, epithelial cells in the ducts. Jaundice is an early manifestation. Usually very asymptomatic until really advanced. Metastasis occurs really early because the blood goes everywhere and the lymphatics go everywhere. 95% mortality rate. So this is the cancer that Alex Trebek had. I know dozens of people that have had pancreatic cancer. And it's one of those things when people tell you they have pancreatic cancer, the correct response is, ooh, sorry. Usually it's measured in months from diagnosis. We will continue with another video on lower GI.